Hello, I'm David Meagher, Chair of Psychiatry at the Graduate Entry Medical School here at the University of Limerick. I'd like to talk to you about the connection between brain and body wellness. Specifically, I'd like to talk about how computer-assisted technologies can help us in our battle against acute brain failure when it occurs in people who are physically ill. Clinicians refer to sudden brain failure as delirium. This is a state that's characterized by confusion, disorientation, and frequently also involves frightening hallucinations and delusional beliefs that one is in danger or under threat. As you can imagine, this is a very distressing experience for sufferers and for their loved ones. My interest in this problem is stimulated by the observation that it is so badly managed in our healthcare environments, such that there is huge opportunity to improve diagnosis and management of this important condition. So first of all, let's talk about delirium. Although Hippocrates first described delirium over 2,000 years ago, it's really only in the last decade that we've started to get fully to grips with the extent of this problem. Delirium is important because it's really common. Recent research here in Ireland has confirmed that 1 in 5 people who enter our hospital seeking treatment experience delirium at some point during their stay. Delirium is also important because it's often the first indicator of serious physical illness elsewhere in the body, such as severe infection or indeed even stroke or heart attack. Being delirious is also very bad for your well-being. Delirious patients frequently develop complications that result in prolonged hospital stays, and for many, they fail to recover their previous level of cognitive and functional independence. And that's for those who survive delirium, because studies show that for each additional day of unchecked delirium, you're 5% more likely to have died 1 month later. But perhaps most disappointingly of all, studies have shown that more than 50% of patients with delirium are missed or misdiagnosed in everyday clinical practice. All of which begs the question, why? A principal factor is our modern healthcare systems are not well designed to provide the kind of joined-up holistic care that links brain symptoms with bodily illness. Today's hospitals are highly specialised, and you can expect your medical team to be very expert in dealing with the primary problem that brings you into hospital. However, for many patients, the physiological stresses of surgery, along with exposure to pain-relieving and other medications, results in delirium. And our hospital systems are not well attuned to picking up these difficulties. As a consequence, although your hip operation may go well, you may develop delirium and not recover to your previous level of cognitive and functional abilities. I expect that many of you may have had the distressing experience of having had an older relative who's been cognitively very sharp go into hospital for what seems like a routine operation, and during that time become confused and then never quite get back to their old selves again. This problem is at the core of what we want to address. Just like MRSA, delirium occurs throughout our healthcare environment and is highly preventable and manageable if we intervene quickly after it occurs. Indeed, better management of brain disorders in hospitalised patients has huge potential to improve outcomes both for individual patients as well as macro issues such as healthcare costs. So what could be done? The first big challenge is to improve detection. At the Cognitive Impairment Research Group, we are interested in developing efficient ways of monitoring brain function at the bedside in our hospitalised patients, just like we do vital signs such as blood pressure and temperature. We know that the earliest indicators of disturbed brain function in patients with delirium are impairments to attention and their ability to visually appreciate their environment. Traditionally, these abilities have been tested by asking patients to do things like to spell the word world backwards, or to count back from 100, serially subtracting 7, or using pen and paper tests like asking patients to draw clocks that indicate particular times. Of note, these tests weren't developed with delirium in mind and are pitched at too high a level of complexity for highly morbid hospitalised patients. As a consequence, they're unreliable when we use them in everyday practice, and our patients often do badly because of issues such as visual abilities, fine motor skills, educational background, or just due to overall level of frailty. So we need novel tests that are simple, pitched at delirium, easy to use, and that are reliable when we use them in our busy hospital environments. Computer-assisted technologies can capture these characteristics. Smartphones, for example, provide an ideal platform to penetrate everyday hospital routines. At the Cognitive Impairment Research Group, we have taken up this challenge, and working with colleagues in computer sciences, we have developed a series of delirium-friendly tests that could be used to assess cognition at the bedside. Our studies to date indicate that these tests are highly accurate for the detection of significant cognitive problems, including delirium, but also that they engage the vast majority of patients in our hospital environments, including those who are very ill and have reduced arousal. I think this is a really good example of how interdisciplinary collaboration between clinicians and other scientists can help us come up with novel solutions for complex problems. So how can we use improved diagnostic practices to the benefit of our patients? We know, for example, that even when we do identify significant cognitive problems, patients often don't receive optimal care, and that management practices vary considerably from centre to centre. Identifying significant cognitive problems should trigger further diagnostic efforts, but at the same time also the rapid implementation of best evidence therapeutic practices according to, for example, NICE guidelines. The big challenge is to coordinate diagnostic and therapeutic efforts in an integrated fashion. At the Cognitive Impairment Research Group, we've taken up this challenge and developed a computerized decision support algorithm. This is a smartphone app which guides assessment not only of delirium, but also of other common neuropsychiatric problems such as depression and dementia. The assessment process is linked to further investigations and also an evidence-based management plan. So where to next? These novel assessment tools are by no means limited to the diagnosis of delirium. The tests are pitched to capture a range of performance so that they provide highly personalised measure of changing cognitive function over time. They're thus well suited to, for example, measuring response to treatment. An exciting possibility is that these tests could also be used to identify patients with more subtle cognitive impairments and allow us to identify those who are at higher risk of developing delirium and for whom we need to consider preventative measures or so-called prehabilitation. Beyond the 3Ds of delirium, depression and dementia, these tools also have considerable potential in improving our assessment of conditions such as acquired brain injury and sports-related concussion. Shakespeare said, "The eyes are a window to the soul." As a modern neuropsychiatrist, I might paraphrase that somewhat less eloquently and say, the eyes provide a portal into the brain. Emerging technologies allow for highly accurate measurement of eye blinking, pupillary size, and eye tracking in response to compelling stimuli, all of which indicate cognitive effort and brain function. Importantly, these methods require very little voluntary effort from the patient and therefore provide a useful way of connecting better with patients who have difficulties with communication, perhaps not being able to speak or having reduced levels of consciousness. If you'd like to hear more about our work or would like to discuss ways that we can better manage brain problems in hospitalised patients, please contact me, David Meagher, at the University of Limerick.